ahead and introduce our speaker today. So Dr. Giulia Coarelli is a neurologist at the Department of Genetics at Sorbonne University and a clinical investigator at the Paris Brain Institute in Paris, France. She received her Doctor of Medicine and completed a neurology residency at Sapienza University in Rome. After a research stay at the Paris Brain Institute during her neurology residency, she moved to Paris to continue her research at the ICM, where she went on to obtain a PhD in neuroscience under the mentorship of Dr. Alexandra Durr. The main aim of Dr. Coarelli's research is the identification of clinical, radiological, and fluid biomarkers in spinocerebellar ataxias. She uses multimodal assessments based on clinical scales, ocular motor recording, ophthalmological examination, neuropsychological evaluation, brain MRI, and blood and CSF analyses for her research. A particular focus of hers is to characterize the pre-Ataxic and early Ataxic phases that will be the target for potential future treatments. So thank you so much for Dr. Coarelli for joining us today, and the floor is yours.
Thanks, Lauren, for the introduction. So it's a pleasure for me to speak with you about SCA2. So good morning, everyone. So SCA2, it's one of the subtypes of Spinocerebellar Ataxia. Today we count 50 subtypes of SCA, and the most frequent subtypes are due to CAG repeat expansions that were discovered before 2000. So about the discovery of the SCA2 gene, in 1993, the locus, so the region on the chromosome 12, was identified in several families that presented autosomal dominant cerebellar ataxia, but we have waited for 3 years before to identify the SCA2 gene, the ataxin-2 gene, and it was done by 3 independent groups in US by Pulse, in France by Imbert, and in Japan by Sampei. So the 3 independent groups discovered the ataxin-2 gene, and the causative mutation is a CAG repeat expansion in the coding region of the gene that results in a polyglutamine stretches in the corresponding protein, the ataxin-2 protein. So if this is the gene, we have a repeat expansion of a triplet CAG, and until a threshold 32, it's normal. Everyone carry an expansion, but above this threshold of 32 units, the expansion became pathologic and it's responsible for this disease. Commonly, the patients have a median of 37 repeats. And about the prevalence, there are some geographical regions that are most where the disease is most frequent due to a founder effect, like in Cuba or in the French West Indies, in Guadeloupe, Martinique, or in India. And about the mechanism of this disease, the transmission is autosomal dominant. So at each generation, you can find some people that carrying the expansion. So, for example, this woman has 3 children, and each children has 50% of probability of inheriting the expansion. But it's in CAG expansion, the future that there is a dynamic mutation with a propensity for expansions. And so, especially in SCA2, we have the anticipation phenomenon. What does it mean? That, for example, we can diagnose the disease in a children, the 3rd generation, that presents a large expansion of 50 CAG, and for example, the father or the grandmother can not yet present the symptoms because they carrying an expansion that was smaller. And for example, and if, especially for the paternal transmission, we have this anticipation phenomenon. So a father that has 35 CAG repeat can transmit a larger CAG expansion with an onset that is earlier, because we know that there is a good correlation between age at onset and CAG repeat size. In this figure, we can see that, for example, for a CAG repeat of 49, we have a median age at onset of 10, 12 years old, against of a carrier with 35 CAG repeat that presented an adult onset with a median age of about 60 years old. So there is a good correlation between age at onset and severity of disease with CAG repeat size. At the molecular level, what is happening in the cells? The problem that when there is the CAG repeat, the pathological CAG repeat, as I said, there is a polyglutamine stretches in the protein that leads to an altered conformation of the protein. And so the protein that presents an abnormal conformation tends to aggregate. So there are ataxin 2 proteins that aggregates, and in the cells we can find the ataxin 2 aggregates, especially in the nuclei. And moreover, this protein does not function very well, and it presents altered interaction with other protein patterns. And so this led to different abnormalities in the cells, like, for example, impaired bioenergetics, but also DNA damage, also a loss of nuclear integrity, and all these major transcriptional changes, and all these changes have as a final event the neuronal death. About the pathology, we know that we have an ataxic phases when the cerebellar syndrome is over and can be accompanied by other symptoms that later I will explain you. And so in the ataxic phases, there is cerebellar syndrome and also cognitive alterations, sleep alteration, psychiatric disorder. But it's peculiar of this disease to have a long pre-ataxic phase from the birth to the onset of disease. And already in these long pre-ataxic phases, we can have some clinical signs or symptoms. For example, at the examination, we can find pyramidal signs, like, for example, brisk reflex or other abnormalities in the eye movement, and also subtle abnormal tandem gait, subtle cognitive impairment. And so at the examination, the neurologist can already identify some clinical signs. But even earlier, we have biomarkers of pathogenesis that we can detect by, for example, brain MRI. So at the pre-ataxic phases, there is already cerebellum or brainstem atrophy, other atrophy of white matter, the atrophy of cervical spine, alteration of white matter, and the spectroscopy alteration too. So there are some changes, some pathological changes that begin very earlier in the life of the carriers, earlier than the onset of the symptoms that the patient can report. And so it's a multisystemic neurodegenerative disease with different systems of the central nervous system that are affected. First of all, the cerebellum and the brainstem. So in this figure, we can see that in this figure, there is the brainstem and the cerebellum in blue. And we know that SCA2 carriers present already the volume that are lower than control. In gray, there are the controls, so people that not carry the expansions. In light blue, the preclinical SCA2 carriers, so that have no symptoms, but they carry the expansion, and dark blue, the patients, the manifest patients. And we can see that already at preclinical level, the cerebellum and the brainstem are present a loss of volume. And this is very important for one region, the pons, in light green. And the pons is the best region that for which we can detect a loss of volume in a pre-ataxic phase. And with Professor Durr, we measured the loss of volume. So in this figure, we can see 5 patients that present a quite linear loss of pons volume. And so at different visits in different studies, but we can see that the patients every year present a loss of pons volume. So about the diagnosis, we can do different tests for the different scenario. So for example, if there is a person an individual that presents the symptoms of SCA2 and with a positive familial history, we can do a diagnosis testing, so a blood sampling to detect the expansion of the CAG expansion in ataxin-2 gene, and this is a diagnostic testing. But we can do also a pre-symptomatic testing, and it depends for each country. There is a regulation that can be different. But for example, in France, we do the pre-symptomatic testing. So an individual that has a positive familial history for SCA2 can ask for a testing to know his genetic status at the majority age, so after 18 years old. And we have to pay attention because nowadays there is no preventive therapies, no curative therapy, so it's an individual choice to know his status. And this testing is done in a multidisciplinary manner. So there is a multidisciplinary team that consists of a neurologist, a geneticist, psychologist, because we have to support the person that want to know the testing, because the test can detect the pathological expansion. We have to support with psychological support these individuals. And the pre-symptomatic testing, it's, as I said, an individual choice. The most frequent reason to have a pre-symptomatic testing in our court is to plan a familiar project, so to avoid the transmission of the expansion. And so there is a third option, that is the prenatal testing. Also for this, it depends by the countries. I speak for France, for example. We can have a prenatal testing, so to know the status of the fetus with prenatal testing, with sampling on trophoblast, and after it's followed by pregnancy interruption, medical pregnancy interruption, or otherwise we can have an in vitro fertilization to avoid the transmission of the expansions, or a third option is the sperm donation in the case of the man that it's carrying of the expansion. So there are the three testing. About the clinical care, the symptoms. This disease is very variable in for each patient, and also in one family, the phenotypic variability can be very large. So, for example, the onset generally happens at midlife, but for SCA2, we have taken into account that there are infantile and juvenile cases, because I said before, the anticipation phenomenon can lead to infantile and juvenile cases that are very different from the adult cases. The infantile and juvenile cases, they lead to for the infantile cases, they lead to the death in the first years of life of the baby, and the cardiac complications are very frequent. And in juvenile cases, the severity of the ataxia is greater, with a loss of autonomy very, very earlier, associated with cognitive decline also. And so we have to take into account that there is the severity of disease is very variable, and mostly explained by the CAG repeat sites. In each family and also interfamily, there is a phenotypic variability, and it's a neurodegenerative disease with a progressive worsening, with loss affecting the activities of daily living. So there is a loss of, a progressive loss of autonomy in daily living activities. And we know by different consortium that the SARA score progression, the SARA is the scale to assess the cerebellar ataxia. The SARA is increase the score 1.5 per year. SARA score is between 0, so no symptoms, to 40, the worst score, and assess the gait, the balance, the speech, and also the coordination of upper and lower limbs. So the different consortium, like for example EuroSCA, calculated a progression of 1.5 point per year. And about the symptoms, the main symptoms is cerebellar ataxia. That means the problem of balance, the problem of gait that are expressed as false, but also problem of coordination of upper and lower limbs, problem to coordination in fine movements. And we have also in this disease the problem of oculomotor coordination, because the oculomotor movements are coordinated by the cerebellum and brainstem. So the patient can present the diplopia, that means the double vision. And we have also detected other oculomotor signs, and the pathognomic signs is the slow saccades, so the slow movement of the eyes, nystagmus, and also the saccadic dysmetria. Moreover, we have dysarthria, so speech abnormalities, cerebellar dysarthria, so the voice is not fluid, and also the problem of swallowing, the dysphagia. And patients can also report the cramps, stiffness in the legs, amyotrophy, neuropathic pain, so pain in the foot, but also in the hands. And especially for SCA2, we can have patients that can present also Parkinsonism, so like a Parkinson disease with very slow and also abnormal posture expressed as dystonia. So in SCA2, we can have Parkinsonism and cerebellar ataxias. So the variability of the phenotypes can be very large. Other symptoms are the urinary symptoms as urgency or constipations, and frequent are also the sleep disorders, are restless leg syndrome, or rapid eye movement sleep behavior disorder, excessive daytime sleep, insomnia. And finally, we can have cognitive impairment that can be present in advanced stage of the disease. And often the patients can have psychiatric symptoms, as for example, depression, that is not, that worsen with disease progression, but there are not, that is not simply the consequence of motor disability in SCAs. So the symptoms in this table, we can see that the different phenotypes are related to the different CAG repeat expansion. So for example, for small expansion, we have more often a Parkinsonism, and that it's explained by the presence of the interruption of the CAG repeat, but the CAA repeat. So we have CAG, 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 CAA, CAA. So this interruption leads to a Parkinsonism more than a cerebellar phenotype. With medium repeat size, we have cerebellar ataxia and slow saccades, polyneuropathy. For larger repeat, cerebellar ataxia is associated more often with chorea, so involuntary movements, but also with cognitive impairment. And for very large repeat that are reported in infantile and juvenile forms, we have another type of clinical examination with fasciculation, myoclonus, dystonia, cardiac failure in the children. So about the clinical evaluation, what do you expect by a neurologist? Of course, a clinical examination with appropriate clinical scales. As I said before, the SARA scale is the best clinical scale to assess the cerebellar ataxia and should be done every visit to follow up the patients and to have a valid score to follow up the patients longitudinally. And of course, the clinician should inform about this disease, how can be transmitted the disease. And so the genetic counseling is important. When there is a diagnosis of SCA2, we have to propose a genetic counseling because there is an impact of all the first degree relatives in the family, because the children or the sister brothers are at risk, at 50% at risk to carry the pathological expansion. And also the genetic counseling is important to support the patients in a family project. And about therapeutic care, the clinician should propose symptomatic treatments, and also to propose a follow-up in a specialized centers that can be proposed also some research project. So the opportunity to participate in a research project, it's taken into account. About the existing treatments, nowadays there is no curative treatments, but we can propose some treatments to alleviate some symptoms. For example, the neuropathic pain is very frequent in SCA2, and there are some different molecules that can ameliorate these symptoms, as for example pregabalin, gabapentin, carbamazepine, and duloxetine. For the Parkinsonism that is very frequent, there are levodopa or dopamine agonists. Of course, these treatments can have the side effects, so we have to try, and every individual can answer well or less well to this treatment. For dystonias of the abnormal posture, there are the possibility to use benzodiazepine, or also in some cases the focal intramuscular botulinum toxin. Also for the tremor that is very frequent in SCA2, for example the head tremor, we can do the intramuscular botulinum toxin that improves the tremor, and of course it's a treatment that can be repeated every 3-6 months, depends by the patient's response. For the cramps and spasticity, we have some neurelaxant as baclofen, but also benzodiazepine, and also for the spasticity, the toxin can be, the botulinum toxin can be proposed. For sleep disturbances, the benzodiazepine can help the patients, but we often use the melatonin for the REM RBD disorders. For leg syndrome, the benzodiazepine and the pramipexole are the first choice. For urinary disturbances, there is anticholinergic drugs or other drugs. And finally, we can propose the urinary catheterization to avoid the urinary infections. Sometimes we can have the seizure and myoclonus, moreover for juvenile and infantile forms, so we have to propose anti-epileptic drugs and benzodiazepine. And for the depression that can be found in SCA2 patients, selective serotonin reuptake inhibitors can be proposed, and of course follow up. So all these treatments exist, but we have to take into account the side effects, and they should be proposed by a neurologist that know well this disease. I think that we have known about the Riluzole. It was a first study in 2015 that show a positive results with Riluzole used for 12 months in a larger population of patients affected by Spinocerebellar Ataxia and also Friedreich ataxia. And with Professor Durr, we conducted a study between 2018 and 2019 to assess the Riluzole efficacy in SCA2 patients. We choose only SCA2 patients because Riluzole is the drug used in ALS patients, and SCA2 patients sometimes can have symptoms that are similar to ALS, and also because there is an interaction between ataxin-2 as a risk factor for ALS. So we choose to conduct a trial with the Riluzole only in 45 SCA2 patients. And we can see that there was a group treated by Riluzole, 22 patients versus a group treated by placebo, so without drugs, 22 patients, and the patients were similar for disease duration, SARA score, the score that assessed the cerebellar ataxia. So there were two groups similar for the disease stage of the disease. But after 12 months of treatment with the Realal, 50 milligram twice per day, we did not find any improvement of any clinical improvement assessed by SARA or another score for the upper limb ataxia, the composite cerebellar functional score. So there was no improvement. And you can see that, interestingly, the placebo group behave better than Realal group, with a change of only 0.3 point of SARA score versus Realal 0.5. And also we regarded if the atrophy in the cerebellum or in the brainstem was impacted by the treatment with Realal, and we didn't detect any improvement also on MRI scans. So we concluded that Realal does not improve SCA2 patients. And it's a drug that can have also side effects, especially for liver enzymes increase. So there are other specialized care that can be proposed to the patients. First of all, the physical therapy. Physiotherapy focused on improved gait, balance, coordination, posture, muscle strength, and is often recommended. The physical therapy should be repeated several times in the weeks, and you can also repeat the exercise at home. There are different types of physiotherapy, but it's very necessary to maintain the clinical status. Another type of therapy that can be proposed is speech therapy to stabilize the dysarthria and to make more intelligible the expression, the vocal expression of the patients, and also to support the patients in the swallowing exercise, because there are some exercises that can help you to avoid the swallowing problems. Orthoptic therapy can be proposed if the patients report the diplopia, so the double vision. So there are some exercises that can be done in patients with diplopia. And of course, occupational therapy and psychological support is very important for the patients and also for the caregiver that support the patients, and also for the individuals that are known to be at risk to carry these expansions. So the specialized care that should be proposed in each stage of disease, in advanced stages, but also in the early stage, to maintain the physical status. And about until now, there are no gene therapies that are ongoing, but for other SCA subtypes like SCA1 and SCA3, there is a clinical trial with antisense oligonucleotide therapies that could be also proposed in SCA2, because in SCA2 there is some positive results with ESO in mice model. So the research in SCA2 is very encouraging, with positive results in mice, and we regarding very closely with other SCAs with the same mutational mechanism like SCA1 and SCA3. So thank you for your attention, and I'm glad for your question. Hello?
And my computer froze there for a second. Thank you so much. And if you wouldn't mind stop sharing screen, that would be great. So I do have a number of questions today, so we're going to try to get through as many as we can in the next 15, 20 minutes. And just as a reminder to please put those questions in the Q&A. So one of the questions has to do with the risk to each of the child of a parent. Does each child have the same risk of having the disease if one of their parents is diagnosed?
Yes, each children is at 50% of probability to carry the expansion. So for each children, the probability is 50%.
Okay, thank you. And have you ever found any success with switching to different diets? So for example, a plant-based diet or a gluten-based diet for slowing the symptoms?
There are no data about the different diets, so I can't respond, but I don't think that the diets can improve or not the disease course. But what improves the disease course is, of course, the physical treatment, so physiotherapy and physical activities.
Are there specific types of exercises that have been shown to slow the progression of SCA2 that you would recommend?
The exercise that focus on balance, and that prevents the spasticity of lower limbs.
Can you name just an example of an exercise like that?
The exercise to, for example, the tandem gait, or the balance in unstable surfaces. So we can do with, of course, with a support of a specialist, of a physiotherapist, and the gait exercise, of course, and also the stretching exercise for the muscles. Mm-hmm. And you can done every day at home, the stretching exercises.
So at what age is it recommended that you test children if they're symptomatic?
But if a child is symptomatic, we have to propose the testing, of course, but if it's symptomatic, if presents symptoms. Otherwise, if it's a children at risk but without symptom, the pre-symptomatic testing can be done, but at majority age.
Can you share the difference between the Biohaven's troriluzole versus Realal, and if you've seen differences in efficacy between those two treatments?
So in the Biohaven study, they use the troriluzole, that is a precursor of the Realal, but is the same mechanism of action of the drug, and they all the results are not yet published, but it seems that in bioeven groups there is an efficacy that prevents the falls, but the main primary outcome, the SARA score, is not reached. So there is no improvement of SARA score. And in bioeven, there is also a mix of different forms of SCA. So there is a SCA 1, 2, 3, I think also 8, 10. So there are also other types that are not behave as polyglutamine subtypes. So we have taken into account that I think that clinical trials should be done in genetic subtypes, in a definite genetic subtypes, because we cannot mix the different subtypes, because the SARA progression, but also other symptoms are different. So for this reason, we decided to assess the clinical trial with Realal only in SCA2 patients.
So at least in your trial where it was SCA2 specific, it didn't appear to have a positive effect with Realal.
Yeah.
And thank you. So we talked about the CAG repeat range. What would you consider to be kind of in the low CAG repeat range for SCA2, and what would be in the high repeat range?
It's a difficult question, because it's not the border of the what is small, what is large, but the threshold is 32. So we can consider that between 32 and 36, the expansion is very small, and you can have the juvenile forms when the repeat it becomes 48 and more, but there is a good correlation. But it's not a definite interval to answer to this question, and we have to pay attention to the interruption of CAA repeat, because when the CAG repeats is interrupted by CAA, the phenotype changes with more Parkinsonism phenotype.
Do all types of genetic testing measure whether or not there's the CAA interruptions, or do you have to get a certain type of genetic testing for that?
Is the genetic testing, sure. When you did the genetic testing, you ask also to search for the CAA interruption.
Mm-hmm. Yeah. I can see where a genetic counselor would be very important in explaining the difference of if the CAA is present or not. So I have a question here about, can you share kind of the main symptomatic differences between SCA1 and SCA2?
Yes, there is a difference, because the main feature is cerebellar ataxia, but for example, Parkinsonism is more prevalent in SCA2. The juvenile forms are more prevalent in SCA2. SCA1, it presents often a more often pyramidal signs, fasciculation, and the progression for SCA1 is the most severe among all polyglutamine subtypes. So SCA1 is the most severe forms.
And then here's another kind of SCA3 related question. Would potential treatments that might come out for SCA3 or other types of SCAs be useful for SCA2?
Yes, the new strategy to treat this disease, it will be to decrease the amount of abnormal protein. And one of these strategies is done by oligonucleotide, the antisense oligonucleotides. So there is two clinical trials that are ongoing for SCA3 and one for SCA1. So if there is a positive result in this trial, we can imagine that the same strategy can be proposed for SCA2, and in the mice model seems to have a positive effect.
So it sounds like some treatments might be able to be used in both, and in other cases, the same treatment might not be able to be used, but the same strategy could be.
Yeah, the same strategy,
right?
Of course,
okay.
Because finally the genes are different, so the proteins are different.
I just wanted to answer one question quickly. There's a couple questions about whether the recording will be made available. And yes, it will. The recording of this talk will be posted to the NAF website, usually within a week of the lecture. So you'll be able to view this again. If you are diagnosed by a neurologist with spinocerebellar ataxia without genetic testing, what reasons would you have for getting genetic testing? Does it matter which type of SCA you have?
I don't understand, sorry. You can
what would be, if you're diagnosed with spinocerebellar ataxia, what would be some of the reasons to get genetic testing to figure out which type?
The genetic test, but to know exactly the gene that it's mutated, and also to do a good genetic counseling for all the family, for the offspring, for the relatives, so to allow to know the gene is mutated, and to do pre-symptomatic testing, prenatal testing, and to better manage the treatment of the disease.
I have a question here about what you would expect to have performed at a clinical exam. What are those exams like from the patient perspective?
The clinical examination?
Mm-hmm.
So the clinical examination is done by a clinician and neurologist, and to assess the main symptoms like cerebellar ataxia, Parkinsonism, the oculomotor abnormalities, and we use clinical scales as SARA or INAS or other. We can propose also, for example, the oculomotor recording to assess very well the oculomotor movements, and the digital outcomes can be very useful for future clinical trials, because the digital outcomes are more objective than clinical examination. So we are searching for good biomarkers that can be clinical, digital, MRI biomarkers, so blood sampling from the blood sampling, or CSF, to monitor a future drug, for example, and to monitor the disease progression. So the clinical examination, it's important, but I think that should be associated with other biomarkers.
And then just a couple examples maybe of some of the tasks patients have to perform during a SCARA test.
Yes.
Would be helpful.
The example?
Yeah.
For example, in the SARA score, we ask to the patients to walk normally, and also in a tandem gait, so with one foot up to the foot, and also the stance. We examine the stance with the foot
touching close together.
Yeah, close together, or in the tandem position. And after, we ask the patient to for the speech, to evaluate the speech. Also the sitting position with the hands like this, without the foot that are in contact of the ground. So like this. And after, for the appendicular task, we ask to, for example, nose to finger. So the patients have to touch his nose and the finger of the examination, like this, or follow the finger of the clinician like this, and the heel shine movement, so with the heel to touch the shin, and for the lower limb. So it's the SARA evaluation, and however there is the reflex with the arm, and
it's kind of a battery of different tasks and
yeah.
things for the patient. Okay, thank you. I have a question about how does IVF work for females who have SCA2 and want to avoid passing the gene down? This individual asks, is it egg replacement, or is it some other approach? Can you explain IVF with pre-implantation genetic diagnosis, how that works?
Yeah. The in vitro fertilization. So you choose, it's in vitro fertilization with the gametes of female and of the woman and the man, to avoid. So you choose the embryos that don't carry the expansion. You choose the embryos, and the embryos are injected in the uterus of the woman. But we have to pay attention, because the problem that for in vitro fertilization, there is a threshold of age of the woman, because, for example, in France is 36, 37 years old, because otherwise the ovarian reserve is not good. And also the problem that the success rate is about 20%. So after in vitro fertilization, 20% it's a positive result.
So just
for the pregnancy.
Just
so
to be clear,
it's not so high.
Just to be clear, both the sperm and the egg come from the parents, but there's genetic testing of the
embryos.
Yeah,
sure.
All right, thank you. So there are quite a few questions about the development of treatments for SCA2. I know you spoke a little bit about that towards the end of your talk, but if you could maybe summarize again where some of the most promising treatments are, and where you see the future of treatments for SCA2.
So for the future upcoming treatments, the one of the most promising is antisense oligonucleotides, because it was already tested in mice models, and because there are other neurological diseases that are treated with success with ASO, and there is 2 ongoing clinical trials in SCA1 and SCA3. So we could imagine that should be also a clinical trial in SCA2. Moreover, there is already an antisense oligonucleotide that targets the ataxin-2 that it's used in ALS patients. So we hope that would be used also in SCA2 patients, because nowadays it's used in another disease. So we hope that we can have a clinical trial in SCA2 patients. Otherwise, there is the gene therapy approaches with, for example, genes that are delivered with a virus, so the gene therapy by viral vector, but it's not yet proposed in humans. So there are some preliminary results in mice, but it's not yet for the patients.
Can you just remind us about how long does it take to bring a treatment from phase 1 clinical trials through being actually available? I know it varies greatly, but just to give us
it's a very difficult question, because it depends by the pharma overall, and if there is no side effects and the phase 1 did not, the phase 1 trial does not report any safety concern, any toxicity of the drug, you can pass to the phase 2 and phase 3, and can be very, not very, but can be rapid. But we have to begin by the phase 1, and in a phase 1 there is a small sample size, about 30-40 patients. So I cannot answer with the exact number of years. Mm-hmm. It depends by the molecule and the results of the phase 1 study.
But it can take up to 10 to 20 years. Would you say that's accurate?
I hope less than 10 years, however.
I have a question about if a woman already has SCA symptoms, would becoming pregnant worsen the symptoms for her?
If the woman with SCA symptoms without diagnosis or with
no, sorry. Does pregnancy tend to worsen the symptoms of ataxia?
No, it's not like multiple sclerosis when after the pregnancy the disease can be faster progression, but in SCA there is no reported side effects of the pregnancy. Of course, when you are pregnant, you are very the balance can be affected a little bit, but after the pregnancy there is no faster progression, so no problem with the pregnancy.
We have a question about Skyclearas or omaveloxolone, which is the drug that was recently approved for FA. Is there any proof that might be beneficial for SCA2 patients, or is that just for FA?
Omaveloxolone, it's a treatment that target a pathway that is impaired in Friedreich's ataxia, so in the mitochondrial bioenergetics that is impaired in Friedreich's. I don't think that can be improve SCA2 patients, but I don't think that it's another pathway.
Well, unfortunately, we still have a lot of questions, but I think we do have to wrap up because we're right at the end of the hour. So thank you so much, Dr. Coarelli, for your time today. This was incredibly useful, and I hope everyone here enjoyed her talk as much as I did. So thanks again,
Thank you very much for your attention.
Have a good